I want to start in Augusta, actually, because I want to talk briefly about the patient, Busilla Stevenson. She was 91 years old. She had pneumonia, she had sepsis, she had acute renal failure. She's admitted to Doctors Hospital of Augusta, and she was actually in the minority of Georgians who had an advance directive. And on admission, her family took in her advance directive and gave it to hospital staff. What did her advance directive say? Basically, no heroic measures, no CPR. But Ms. Stevenson is intubated and is put on mechanical ventilation. Plus, in the next few days, she's given a feeding tube, blood transfusions, a bronchoscopy, tracheostomy, and more. Clinicians there, right, violated the advance directive, which basically said stop, but clinicians said go. And what happened is the family sues Doctors Hospital of Augusta for violating the patient's advance directive. And that case settles for $1 million. Plus, the case goes to the Supreme Court of Georgia, which clarifies that, quote, a clear objective of the 2007 Georgia Advance Directives Act is to ensure that the will of the patient, not the will of the healthcare provider, is what controls. Right? They treated her advance directive kind of like a Christmas wish list, right? Well, this is what I hope to get. But in fact, compliance is mandatory, right? We know that because that's what the Georgia Supreme Court said. Plus, it's in the Georgia statutes. It's in the Advance Directives Act, which says a decision made by the agent shall be complied with. And it's in the hospital licensing regulations. Quote, the hospital shall ensure the advance directives are honored. Plus, it's in the Medicare conditions of participation for hospitals, which basically say you have to follow state law. So that $1 million settlement, that was just in that one case in Georgia. But if you look around, a lot of headlines in the last couple years about people suing successfully when an advance directive is not honored. A lot of verdicts, a lot of settlements. Why? Why do we see that? Well, because advance directives matter, right? Why do they matter? Because they help assure value concordant treatment, right? They help assure that patients get the treatment that they want, and also that they don't get the treatment that they don't want, right? So if you get too little treatment, of course, that can be harmful. But also, if you get too much treatment, that's also harmful. And how much is too much? That's a value-laden judgment, right? And that's recognized in Georgia law, right, that this is a preference-sensitive decision, right? How you balance off the burdens against the benefits of any treatment is a trade-off, is a balance for the patient to make. And we see that there are two key types of value-discordant healthcare, right? Over-treatment and under-treatment. And both of these happen to patients with decision-making capacity, but they happen a lot more to incapacitated patients, right? Why? Well, naturally, because they can't tell us what they want, and they can't tell us what they don't want, right? Because they're intubated, or they're sedated, or they're unconscious. A key tool to mitigate value-discordant treatment for incapacitated patients is the advance directive. So I should pause, and I hesitate because I have no idea how this is going to turn out, but who here has completed an advance directive? Okay, well, we would expect, but just to note, even in this crowd, which is a select crowd, not a hard, and maybe a follow-up question, right, which is who here knows or is confident that their agent has a copy of that advance directive? So not just that you completed it, but you know your agent has it and knows where it is. All right, well, nobody, okay. So here's the roadmap. Just three parts. This is a three-part talk. First, the role of advance directives. some problems and challenges that we're facing with respect to advance directives, and then ending on some solutions and fixes. All right? So I think we should start with capacity, right? What is decision-making capacity? Typically, as a three-part definition, means that the patient is able to understand the significant benefits, risks, and alternatives to the proposed healthcare. So it's an understanding requirement. She's able to reason and make a decision, and she's able to communicate that decision. Okay, if the patient has capacity to make the decision at hand, then the patient can decide herself, her own health care. And everybody's presumed to have capacity, so there's really never a need to prove that a patient has capacity because they're already presumed to have it. So really, the burden on the clinician is to prove incapacity, prove that they don't have it. And sometimes that's easy, sometimes that's obvious. So for example, patients in advanced late-stage dementia or patients in a vegetative state. But it's often, other times, unclear whether the patient has decision-making capacity. So you gotta assess capacity carefully. And I just wanna, before we get to the advanced, because this is the foundation to advanced directives, give 3 quick warnings. Warning 1, capacity is not all or nothing, right? The patient might have the capacity to make some decisions, but not others, right? She might lack the capacity for complex decisions, for surgery or something, but still have the capacity to make simpler decisions. So for example, what to have for dinner, or more importantly, still have the capacity to appoint her healthcare agent, even if she can't make the underlying healthcare decision herself. Warning 2, capacity fluctuates over time. So the patient might, for example, have capacity in the morning, but not in the afternoon. So, among others, the American Geriatric Society warns that except in cases of obvious and complete incapacity, an effort should always be made to ascertain the patient's ability to participate in the decision-making process. And third, even if you did those first 2 things and the patient really does lack capacity to make the decision at hand, that incapacity might be reversible, right? And so you should try to restore capacity if restoration is possible. And there's this great chart in this journal called HCC Forum where they have, and this is just the A's, where it goes on and on with, these are all the reasons why the patient might lack capacity, and then on the right side are all the interventions that might be taken to reverse that. So just as an easy example, if the patient is intoxicated because of alcohol or substances, then you can detoxify them, and now they have capacity again, right? So lots of times they're incapacitated, but that's not an irreversible state, right? And the reason to undertake these measures is because if at all possible, we don't want to have to use an advance directive. We would prefer to hear directly from the patient herself. And one quick way to do that is with supported decision-making. This is different than surrogate decision-making or substitute decision-making, because with supported decision-making, the patient is still in charge. What you're doing is you're getting somebody to help her, to collaborate with her, to understand what the clinicians are saying, and to help her reason about her choices. So if the patient is able to make her own decisions, the patient can decide. Here, what we're saying is if the patient can decide with help, then help her, right? And then she can still make her own decisions with that help. And so there's these things that are similar to advanced directives but different, called supported decision-making agreements, where you're appointing what's called a supporter, right? Somebody to help you make your healthcare decisions. And that's growing. A number of states have passed statutes authorizing supported decision-making arrangements. And I don't think there's a statute yet in Georgia, but there are some efforts to implement supported decision-making even in Georgia. Okay, so just to sum this part up, I just gave you these 3 warnings, right? Assess capacity carefully, restore it if you can, and try to preserve it if you can. Because we don't want to have to turn to second best substitutes unless we really have to. But of course, some patients really are gonna lose capacity, and we're not gonna be able to bring it back, okay? So these patients can no longer make their own healthcare decisions. They need a substitute, somebody who can speak for the patient when they can't speak for themselves. Now, ideally, people would appoint their own substitute decision maker, their own healthcare agents. And normally you do that with or through an advance directive, right? And of course, there are two parts to an advance directive. There's the instructional part and there's the appointment part. So the instructional part used to be known as a living will. You record the treatment you want, you record the treatment you don't want. There's a ton of paper forms, electronic forms, apps. These are just some of them. Some of them are more treatment focused, right? So like this one, which ends up being very complicated with the grid, where you have all the different things. You have CPR, mechanical ventilation, dialysis, and so forth. And then you have all the different conditions under which you might want or not want each of those interventions. Super complicated. Other advanced directives are more goal focused instead of being intervention focused. So like 5 wishes, where instead of getting into specific treatments, you just say these are the things that make life worth living. So it's a much higher, less specific level. Anyway, the advantage of all of these instructional advanced directives is that you get to hear from the patient herself, right? Because the best decision maker for you is you. But there is a big backlash to the instructional directive. It started a while ago. You see headlines like the failure of the living will, or the false promise of advanced directives, or advanced directives, clear, simple, and wrong. So people are saying like the instructional part of the advanced directive is a little too hard. We should really focus more heavily on the appointment part of the advanced directive. And the basic idea of that argument is that the agent can respond dynamically to whatever clinical situation arises. It's really hard for the patient to predict all the potential future clinical scenarios she might find herself in the future. The agent she appoints can be there in the moment and respond. Well, our top choice, our first choice for the person to be that agent is somebody the patient picks herself, right? In fact, we call that person the healthcare agent. Who is that? Well, hopefully it's somebody who meets all 6 of these attributes, right? Somebody who knows the patient, somebody who cares about the patient, somebody who's willing to serve as the healthcare agent, somebody who's willing to honor the patient's wishes and preferences and values to the extent they're known, somebody who's able to serve, because lots of times that person might have their own health issues, or they might not live near where the patient is, and somebody who's a good advocate. Okay, so just to sum up this part, the objective of advanced directives is goal concordant care. And there's 2 mechanisms to help achieve that. The patient can record her preferences and values in the advanced directive, and the patient can appoint her healthcare agent and hopefully a backup or alternate agent in her advanced directive. So those are the 2 ways we can achieve goal concordant care with an advanced directive. The problem is there's so many obstacles to these things actually working and achieving that goal. I'm just going to give you 3 of them, 3 of the big challenges. One is prevalence. Even as our poll suggested a minute ago, a lot of people haven't completed advanced directives. This is in Health Affairs. This is the biggest study ever done on advanced directive completion rates. It's a systematic review of 150 other published studies involving a total of 800,000 people or subjects in the studies. They found that the US advanced directive completion rate is 37%, right? 73% of adults have not completed an advanced directive, right? Not so good. Now, if you look beyond that, this is from a Pew Research Center, same thing, 35% completion rate. Now we can dig into that a little bit and break it up by age, right? So the good news is, if you look at older people, statistically for whom an advanced directive is going to be more relevant, it does get a little bit higher. In fact, advanced directive completion rate is positively correlated with age, as you might expect, also with income and also with education. This is CDC data. If you look on the right, you see at least of hospice patients, the advanced directive completion rate gets to 88%, which you might expect. But that middle section, nursing home patients, only 65%. Now CDC breaks that apart by age. So older nursing home patients, it does get up to 77%, but that's 85 plus, right? So even for nursing home patients who are 80 years old, the advanced directive completion rate is only 65%. Now that's better than the overall US rate of 37%, sure, but that still means that 1 in 3 80-year-old nursing home residents does not have an advanced directive. Okay. Bottom line is completion rates not so good. Why? Well, I want to just break it up before and after COVID, right? We don't like to think about death, right? Now, that's not limited to advanced directives. Most Americans don't save for retirement. They don't have a 401k or funded 401k. Most Americans don't have a will for how to distribute their property upon their death. I loaded this app in my phone. It's called We Croak. And the whole purpose of this app is it sends you reminders several times a day saying, don't forget, you're going to die. Now that's really what it does. It's free. It's a free app. You can load it yourself. Most of you work in hospice. You probably don't need that app. But now during COVID-19, we didn't need that app either because sort of death was constantly in our minds, right? On the news every night, you're telling us how many people died from COVID. And many hospitals have refrigerated trucks parked outside in the parking lot because the morgue is overflowing. Okay. Well, the consequence of that is that death, it was more salient in society. And the advanced directive completion rate did shoot up over the last few years. That is good news, okay? And you see this, a lot of headlines, pandemic increases healthcare directives, advanced directive demand is up. This is Journal of Pain and Symptom Management from West Virginia. They reported or found a 400% increase in advanced directive completion during COVID. This is an article in JAMA from Philadelphia. They found a 500% increase in advanced directive completion rate. You just see left to right. The left is still 2019, and as soon as you get into March, April of 2020, you start to see it spike up. More studies, just showing, if you just see left to right, as you get into COVID, you see the advanced directive rates doubling or tripling as compared to early 2020 or 2019. 5 Wishes, which is one of the most widely used advanced directive instruments probably on the planet, reported a 1,000% increase in demand for 5 Wishes. CAKE, which is an advanced care planning app, reported similar numbers, around 1,000%. And you see headlines even locally in Georgia, like more Georgians completing advanced directives. But unfortunately, when you go back and look into this data a little bit, it looks like it's a blip, right? Because now people aren't thinking about COVID as much. None of us in this room are wearing masks, right? So it's receded, and so things have fallen back down. We might get another blip up because of the massive amount of media coverage that Jimmy Carter has been getting over the last couple of weeks. But still, it's likely again to fall back down to the baseline. So just to recap, obstacle 1, they're not completed. But there are more obstacles, unfortunately. Second one is availability, okay? So now let's say you completed the advanced directive, you filled it out, you signed it. Where is it? Where is it? Or as this New York Times headline says, where's that advanced directive? Unfortunately, they are often missing. This is a HHS Commission study which found that 76% of physicians whose patients had completed advanced directives don't know that they exist. In other words, the physicians don't have them. The patients completed them, but the physician doesn't have them. This is another study, Journal of Palliative Medicine from Los Angeles. Among patients who completed an advanced directive, only 15% of them were in the patient's medical record. Because what patients do often is they complete the advance directive and they put it in a drawer, put it in a file cabinet. So completing an advance directive is not the same thing as having an advance directive. Or maybe to be more precise about it, the patient has it, but that's useless, right? Because what you need is that you need the healthcare provider to have the advance directive. I think this is a fair analogy. If you get a check, somebody writes you a check, right? If you just put it in a drawer, those funds are not going to be transferred into your bank account, right? You need to endorse the check and then you need to deposit it, right? To get the benefits of the check. Well, the same thing with the advance directive. The patients need to make and distribute copies of that advance directive, especially to their primary agent and to their backup alternate agents, maybe to others like their attorney or their primary care physician. And it would be helpful to, as many local estate planning attorneys recommend, to upload it into a registry, right? So we don't have to go even find the physical copy. Okay, so that was the second obstacle. There's still more, right? The third one, is it updated? Is it updated, right? So let's say you have the patient, she's completed an advance directive, and we actually have it. And just by the way, if you do the math, right, if only 37% of Americans complete advance directive and only 24% of them are actually found or available, you're down to a pretty small number of people. Okay, but they're often out of date. There used to be an advertisement for like some little chicken rotisserie thing, and the idea was, the motto was, set it and forget it, right? You just put the chicken in, walk away, and come back a few hours, it's ready to eat. Okay, well that's how people often treat advance directives. Took care of that, set it and forget it. Well, you gotta review the advance directive as you age and as your health changes. Let me just give you an example. This is a case, a Georgia appellate case decided just in the last year. And basically what happened in this case is the patient had been a Jehovah's Witness. And because of that, had appointed other members of her church to be her healthcare agents, but then later left the church, but still had not updated her advance directives. Her daughters had to go to court here and convince the judge that the patient, since she's left the church, would not want the members of the church to still be her healthcare agents, and they were successful and said, well, we're the better agents at this point. So the recommendation is to update your advance directive at any of the 6 Ds, right? Upon the death of a family or of somebody in your family or a friend, upon divorce, because typically people appoint their spouse, whenever you get a new diagnosis, when there's a significant decline in your health at every new decade, and whenever there's a change of domicile, which I think is specifically if you move from living in your own home to moving in a long-term care facility. And if you get to the point where, as Dr. Christine said a minute ago, where clinicians would not be surprised if you died in the next year or two, then you should supplement your advance directive with a post. Okay, just to sum up this, I gave you 3 challenges. Advance directives aren't completed, they're not found, and they're not updated. The consequences of all of that is there's a lot of medical error. If you don't plan ahead, then you're subject to the default rules. And default rules produce bad outcomes a lot of the time. This is a completely true story. So I just a few weeks ago, I went to Portland for a conference, and I forgot when I bought the ticket on Delta to click my seat when I purchased the ticket. Really sad, because then what happened, of course, is I get the default seat, which is this middle seat at the back of the plane. Okay, similarly in healthcare, the default rules often produce unfortunate outcomes. Probably bad for your patient, right? Because the default is aggressive, curative directed therapy, no matter how sick the patient is. But most people don't want that, right? There's a massive amount of Gallup, Harris, Pew, and other survey evidence on this. This is just one quick stat, right? That 73% of Americans, if doctors believe there is no hope of recovery, what would you prefer? Most people by far say life-sustaining treatment should be stopped and we should focus on comfort. If you don't have an advance directive, you're likely to get unwanted medical treatment. So there are harms from not having an advance directive. Harm number one, you might get the wrong surrogate, right? 80% of incapacitated patients don't have a healthcare agent, right? So who makes decisions for those incapacitated patients? What we call default surrogates, right? Which is our third choice, right? We're already down to our third choice, because our first choice would be the patient makes her own healthcare decisions. Second choice is the person making decisions is somebody that the patient chose to make decisions for her, or the agent appointed in the advance directive. So now we're down to the default surrogates, right? Our third choice. This is somebody that's not chosen by the patient. They're chosen off a list. And almost every state has a list. Minnesota doesn't, but most states do, right? So Georgia has a list in the statute, and I recognize there might be a different statute for DNR, but generally for healthcare, it's this list: adult child, parent, adult brother, sister, grandparent, so forth, right? It sets up this is the default choice if you didn't pick somebody yourself. The problems with this is it might get you the wrong surrogate. And what I mean by that is many patients prefer somebody who's not even on that list. This is a study from JAMA about patients with next of kin relationships outside the nuclear family, because that list is focused on the nuclear family. And so most people, of course, would prefer the nuclear family, but a significant number of people would prefer somebody like an in-law or step-parent or step-sibling, not on the list. Second problem is the Georgia law has a strict sequence, a strict hierarchy, right? It has to go like this: adult child, parent, adult brother, sister. It's strict. So even if the patient's preferred surrogate, or the person that knows the patient the best, the person that cares about the patient the most, is on that list, they might not be ranked at the top of the list, right? So in other words, the priority sequence in the statute might not match the patient's preferences. So it is, just as an example, an adult sibling might often be the best surrogate or a better surrogate, but child trumps, no matter how crappy the relationship is between the child and the patient. Plus, this is all patient-focused considerations. Of course, if the patient had identified the surrogate, that would also help avoid a lot of anxiety and perhaps even conflict among the family. So there are family-oriented considerations as well. So just to recap, there are risks from not having an advance directive. Risk number one is you get the wrong surrogate. Risk number two is you don't get any surrogate. You have no surrogate. And this is a really big problem for healthcare facilities, and in fact, increasingly common. Really challenges both hospitals and long-term care, right? You have a patient, they need treatment, but they don't have capacity and they don't have a surrogate, right? The patient can't consent, she's incapacitated. Unfortunately, there's nobody else to consent. There's nobody else to authorize anything on her behalf. And this goes by various terms. Sometimes they're called unrepresented, adult orphans, patients without proxies, people who are incapacitated and alone. But the most common term is unbefriended patients. That's the term that's used by the American Bar Association, by the Long-Term Care Ombudsman, and by the American Geriatric Society. I led another American, I don't know, they're so nice to me. I got to author yet another American Thoracic policy statement on this problem. We went with the term unrepresented. So who are these patients? Well, again, they lack capacity and they lack an agent, nobody on that list, that Georgia list, nobody's available, right? They don't have anybody on that list. So there's nobody to consent to treatment. And it's a big problem. The hospital estimates are this is about 16% of all hospital admissions, about 5% of all ICU deaths, which would get you about 25,000 patients a year. And these numbers probably are right, because if you look around, the UK has a really similar number of about 4%. And this has been measured in Georgia specifically by some different foundations. And in fact, I even worked on a Georgia-specific study on the prevalence of unbefriended patients. So we have a lot of unrepresented patients. What's the problem? Well, there's a lot of risks and harms. These people can't advocate for themselves, and they have no substitute advocate. So these are described as highly vulnerable, the most vulnerable people in all of society. Unimaginably helpless. And the problem when there's nobody to authorize treatment is, what do clinicians do? 3 bad things. 1, under-treatment, right? So they're reluctant to act without consent because they've been trained you always need consent, right? Otherwise it's a medical battery. So they wait, right? What are they waiting for? They're waiting until the condition turns into an emergency, and then they can act on the basis of the emergency exception, on the basis of implied consent. Well, that's not so great, because it means you're literally subjecting the patient to a longer period of suffering and letting their condition deteriorate, increasing risks to the patient. In fact, the Institute of Medicine, or now it's called the NASEM, National Academy of Medicine, says this approach is ethically troublesome because to wait until the condition turns into an emergency. The second approach that's taken is over-treatment. So people are afraid they're going to get in trouble for not addressing a healthcare need. They fear liability, they fear regulatory sanctions, so they treat super aggressively. Well, that exposes the patient to burdensome and unwanted treatment, and the IOM says this compromises consideration of patient preferences and patient best interest. And the third problem is, since there's nobody to literally authorize or sign the paperwork, there's no discharge to a more appropriate setting, right? So the patient stays in the hospital. They don't need to be in the hospital, but they're subject to all the risks of being in the hospital. And they don't get the benefits of going to rehab. They don't get the benefits of hospice. So if there's no decision maker, that results in patient harm. And the best way to protect the unrepresented is to prevent them from becoming unrepresented in the first place. And so in our relatively new policy statement on this, recommendation number 1 of all the recommendations is, before they lose capacity, get them to complete an advance directive. So to recap, if you don't have an advance directive, you're subject to the default rules. The default rules create risks. Risks that you get the wrong surrogate, and risks that you get no surrogate. And risks that you're exposed to unwanted medical treatment or value discordant treatment that you didn't want. Plus, if you don't have an advance directive, you lose all the other benefits of having an advance directive. By the way, these are evidence-based benefits. This is one example, but this is a systematic review of other systematic reviews, right? And what it finds is, when you have an advanced directive, when you have advanced directives, that results in less hospitalization, fewer ICU days, more use of hospice, lower costs, less family anxiety and depression, greater satisfaction, and a better quality of life. So let's say you have the advanced directive, it's been completed, and it's available, and it's been updated. Okay, great. Unfortunately, still more obstacles. Unfortunately, advanced directives are often misinterpreted. There's a group of research studies called the Triad studies. There's 13 of these. And Triad is an acronym. The Realistic Interpretation of Advanced Directives, TRIAD. And most of these have been published in the Journal of Patient Safety. And I'm just going to give you 2 quick findings from these studies, 2 common errors in hospitals and other clinic environments. First one is that the majority of clinicians incorrectly interpreted advanced directives and DNRs as synonymous. In other words, most clinicians think if the patient has an advanced directive, therefore she is DNR. Which is wrong, because an advanced directive is not the same thing as you can write the advanced directive however you want, right? So to know whether a DNR is appropriate, you need to actually read the advanced directive to see she might be asking for full code status in the advanced directive. So that's a very bad error, but it's a super common error. And the second one is a majority. No, this is majority, right? This isn't like, it'd be bad enough if it was 20%, but a majority of clinicians incorrectly interpreted DNR as do not treat, right? So in other words, if they think if the patient has a DNR order, that means don't treat them, or at least treat them less aggressively. But again, DNR does not mean do not treat. DNR refers to one specific intervention, CPR, and shouldn't affect the global scope of treatment. Okay, so that's enough on the problems and challenges. Let me turn to fixes and solutions. And of course, there are so many, we don't have time. But let me just give you a quick snapshot and then focus on two. So going all the way back to 1990, after the Nancy Cruzan case, Congress passed the Patient Self-Determination Act, right? Which says whenever you're admitted to a hospital or long-term care facility in the United States, they have to ask you about, do you have an advance directive, and if you don't, do you want to complete an advance directive? That's now been built into the Medicare conditions of participation for all those facilities. I'm just jumping a few data points here. Fast forward up to 2016, we now have codes that clinicians can bill for doing advanced care planning and get paid for doing advanced care planning discussions with patients. In 2020, during COVID, we got a lot more flexible. And there's a couple examples here. So obviously, advance directives need to be either witnessed or notarized. During COVID, that was harder because of social distancing requirements. So most states expanded and have permitted remote notarization and remote witnessing, which again makes it easier to complete an advance directive, removing more obstacles. Also in 2020, another example of being more flexible, is generally healthcare providers cannot be witnesses for advance directives, right? So I think in Georgia they can be one of the witnesses, but not both of the witnesses, right? Because they have a conflict of interest. Well, our single biggest healthcare system in the United States, the VA, said, you know what? They passed some regs, and they said, you know what? We're going to remove the bar on our VA employees serving as witnesses because it's just an unnecessary burden to the completion of advance directives. Because these people, the only people they know, these long-term residents, are the people that are their healthcare providers. And then just one last example, right? We see a lot of innovation, a lot of tools. These are just games like the Hello game or the Go Fish game, right? Lots of tools and instruments to help facilitate advanced care planning discussions. So we see innovation at the federal level, at the state level, and from private organizations. I just want to zero in on two things and then I'll be done. And the first one is to address that first problem of the low advance directive completion rates. And here, I want to recommend patient decision aids. So and this is just one study, but one of the things that many studies measuring obstacles to advanced directive completion identify as an obstacle to completion is that patients don't understand their prognosis. In other words, they are unaware that an advanced directive is imminently going to be relevant for them. And the problem is widely measured. Only 12% of clinicians talk about end-of-life planning with their heart failure patients. 78% of people with an ICD think that that's going to forestall further cardiac deterioration when it definitely will not. In the cancer setting, only 31% of patients with advanced cancer have had end-of-life discussions with their oncologist. And there's so many, we could spend the entire hour just doing studies like this, but this is just one example. This is a New England Journal of Medicine study, right? So our best journal, where the question is, these patients are getting palliative chemotherapy, right? For advanced cancer. If you look on the left side, there's two rows. One is, these are for lung cancer and colorectal cancer. So the one is, on the left side, you see that there are 20 to 40% of the patients think that the chemotherapy they're getting is very, very likely to cure their cancer when it definitely will not. And their clinicians know it will not. And if you add that to moving to the right, if you add up the very likely plus the somewhat likely, now you actually have a majority of patients with advanced cancer thinking that the chemotherapy might cure their cancer. So there's this big gap, right, between the theory of informed consent, that we should tell patients like what their prognosis is, and the actual practice of informed consent. And I think one key way to bridge the gap is with patient decision aids, sometimes called decision support tools. What are these? These are evidence-based educational tools. They come in two basic types. They can be used before the physician-patient encounter. So it might be a video, might be an app, an interactive app. It might just be printed, paper literature. They could also be used during the physician-patient encounter. So for example, option grids, which just lay two options side by side and compare them. Either way, patient decision aids present options clearly and very graphically. And one of the most effective forms of decision aids are videos. So for example, with CPR, you literally show it, right? You say this is intubation, this is delivering electric shock. And this is just one study where if the patient, these are people with advanced cancer, if the clinician just talks to the patient about code status, you see on the left, you have about a 50% DNR consent rate. On the right side, in the study group, the only difference between the two groups is the group on the right. They watched a 3-minute video, 3-minute video depicting CPR, describing CPR, in addition to having that talk with their clinician. And you see that the DNR consent rate went from 50% to 80%, right? Really big impact. So do they work? Do patient decision aids work? Yes. There is robust evidence showing that they're highly effective. We have more than 130 randomized controlled trials involving more than 30,000 patients with 50 different healthcare conditions. Those studies have been meta-reviewed, systematically reviewed by the Cochrane. There have been other systematic reviews published. And basically, there are 6 big benefits from using a decision aid as opposed to just traditional polysyllabic clinician-patient discourse. Vastly improved knowledge on the part of the patient, more accurate expectations from their healthcare. They make more value congruent choices, higher patient satisfaction, less decisional conflict, less patient anxiety. So, really good tools. What's the problem? Nobody's using them. They haven't been incorporated. This is all research stuff. This is all lab stuff. This hasn't been incorporated into mainstream healthcare. Right? Very few clinicians are using decision aids. They've been there's a lot of recognition and a lot of endorsement. So if you look around, you see all these national professional societies saying, oh yeah, decision aids, great, we should use decision aids. Okay, great. It's great to get that kind of endorsements and statements. But when you look in terms of actual implementation in the clinics, it's a different story in terms of actual adoption. Things not so good at all. The terms that are used in these studies that measure these things are terms like seldom, incomplete, infrequent, stagnant, elusive, and rare, right? So there's an adoption problem. Medicare is increasingly providing incentives to clinicians to use decision aids. But we do need a strategy to promote wider uptake and of decision aids and shared decision making. If there was more use of decision aids, patients would be more informed. If patients were more informed, then they could make more value congruent choices. And if patients were more informed and they knew their prognosis and their options, they would complete more advanced directives. And importantly, not only would there be more advanced directives, but they would be better advanced directives because patients would actually have a better understanding of the treatment choices they're making in those advanced directives. And let me just end by giving you one more tool. Decision aids are clinician to patient communication. How is the clinician communicating to the patient to make her aware of her options? Let me just end on the other direction, patient back to clinician communication, which is sort of what advanced directives are. To address the misinterpretation problem, which I described, increasingly people are using video advanced directives, right? So traditionally advanced directives are paper or at least document, maybe they're electronic document based, but increasingly people are using videos. This is on the rise. You see a lot of companies like My Directives and Vimti and Mideo pushing out tools for video advanced directives. And this helps in 2 respects. It helps confirm the validity of advanced directives, and it helps confirm the meaning of advanced directives. And just quickly on the validity, it's not uncommon that somebody claims that the patient lacked capacity at the time she completed the advanced directive, and therefore the advanced directive is not valid. This is a case from New York, from Mount Sinai in New York. The patient was 91-year-old Arlene Lester, and her son Kyle wanted his mother removed from life-sustaining treatment pursuant to her 1991 advanced directive. Should have been updated, but okay. Her other son, Edward, says that his mother executed a new advance directive, and pursuant to the new advance directive, would want that life-sustaining therapy. Now, the normal rule is that a later in time advance directive automatically revokes the earlier, so the newest one controls. But the question is that newer advance directive valid? This is the question that the court had to face. In other words, to know whether it's valid, the question is, did Arlene have capacity to complete the newer advance directive? Well, it really helped that we actually had a video of Arlene completing the advance directive, and where we could watch it and have a sense, okay, it looks like she understands what she's doing there. So video really helped there. One other case on this, in California, Sumner Redstone, 92 years old, multi-billionaire owner of, or majority shareholder in CBS Viacom. He had named as his healthcare agent his companion, Manuela Herzer. But then, subsequently, far younger, subsequently named a new and different agent, effectively firing Manuela Herzer as the agent. Well, she didn't want to be fired as the healthcare agent, so she says Sumner Redstone didn't have the capacity to execute the new advance directive, therefore the new advance directive is invalid, and the old advance directive is still in force, and I'm still the healthcare agent. Well, this goes to court, Los Angeles Superior Court, and they bring in the best there's a lot of money at stake, they bring in the best geriatric psychiatrists and so forth and so on. But when you look at what the court decided, what really convinced the court that Sumner Redstone had capacity to complete the second advance directive is a video of Sumner Redstone explaining why he changed his agent appointment. And the judge is like, well, it looks like he understands what he's doing. He had capacity, it's a good directive. Okay, so validity requires capacity. It also requires voluntariness. And sometimes somebody claims that somebody was coerced or put under duress when they signed an advance directive. And again, the video helps confirm that they are signing freely and voluntarily. Okay, so video helps confirm the validity of advance directives. Whether that's affirming the capacity or the voluntariness. But the other thing it helps is confirm the meaning, the intent of the advance directive. What did the patient want? And did she want it under these circumstances? Well, one of the triad studies that I mentioned earlier measured this, and what they found was that adding a video message or testimonial had a significant impact on increasing consensus in terms of the clinician doing what the patient had intended. Because after all, literally with the video advance directive, you're literally hearing the voice of the patient. I mean, people often use that metaphor, advance directives help the voice of the patient come through. Well, here you literally have the voice of the patient. You have her intonations and you have her facial expressions and so forth. It gives everybody more confidence, not just the clinicians, but the family, that yes, I guess she really did want this. I guess she really did, this is a true and genuine desire. Okay, in just a few weeks is coming up on April 16th is National Healthcare Decisions Day, right? Formally declared as such by former Georgia Governor Perdue. And the point of it, right, is of course to inspire, educate, and empower people to do advanced care planning and complete advanced directives, right? And you can go to nhdd.org, and there's lots of tips and strategies on how to promote advanced care planning. And I looked at the map, they have a map there showing who signed up, and you can look, people have already signed up to do things for National Healthcare Decisions Day in this area. That's good. But when you look at overall demographic trends, pretty soon 1 in 5 or even 1 in 4 Americans is going to be over age 65, right? So we're going to have even more people with serious advanced illness, and we're going to have more risk of unwanted medical treatment. And therefore, we are really facing an even greater need than we already have to elicit and document people's goals of care. So let me just end by paraphrasing Winston Churchill when he said, right, that no one pretends that democracy is perfect, and it's even been said that democracy is the worst form of government, except for all the other ones that have been tried. Well, similarly, advance directives are not perfect, but they are still the best means to help achieve value, congruent care for incapacitated patients. Thank you.